for the tips and tricks of rotablation and how to combat different type of complications. And in this session, the discussants or chairpersons are Dr. Imad Shiban, Professor Dr. Mir Jamaluddin, Dr. Atul Mathur, Dr. Aftab Khan, Dr. Ashok Datto, Dr. Kaisan Nasrullah Khan, and Dr. Arun Mohati, Dr. Rupali Khanna, and Dr. Upul, and the facilitators are Dr. Dhiman Bonik and me, Dr. Sakib Shahriar. And I am requesting our senior faculties, please take your seat in the upfront. Our first presenter is Dr. Aftab Khan from India. He will be talking on rotablation, when and how.
The battery just dried out on me. I think we are at the end of the day almost, and again, this is a session where we're going to talk about rotablation and how basically it helps us in our clinical practice. Since it's a small crowd, I think we can have more interaction rather than a lecture. But again, what exactly is a rotablation system is basically it's a system which has a diamond tip burr which basically ablates the calcium in the fibrous plaque, and this includes certain equipment that all of us have to be aware of. There is the console that we all know about. That's the driver which drives the burr, and there's a dynaglide foot pedal which controls the dynaglide mode, and the foot pedal which accelerates the burr. And of course, you need compressed air or nitrogen, and there are these tanks and attachments. So this is the rota system that we were all used to, and now what we have moved on to is what is known as the Rota Pro system, and this is the system that is now available. The advantage of the Rota Pro is that it is a single operator. You don't need two people to help you out with this, and it has made life easier. You can see all the RPMs, and you can see the RPM drop. You can see the speed and the duration of your burrs, burring time. Everything is noted on the display in the front, and it's a single console that makes it easier for us to manage everything. The foot pedal, which had the dynaglide and the foot pedal to accelerate the burr, has also been moved away to the handle shaft. So here you have the brake and you have the dynaglide mode here. So you just have to activate the dynaglide mode from there, and the burr can be activated by just pressing this button on top. So you don't need the foot pedal, and this is the advancement in the Rota Pro, which is now used more commonly rather than the old system. What we need to understand is that the dyna burr has the different sizes. So the 1.25 to 2 millimeter burrs are the ones that are commonly used in clinical practice. 1.5 is the burr that is most commonly used in our clinical practice. And if you look at the shape of the burr, the 1.25 is more tapered. It's like a bullet. And though this is an advantage, it can go through many of the calcific lesion. The disadvantage is that sometimes it may get trapped because of the fact that there are no diamonds on the back part of the burr to pull it back. And therefore, looking at this shape and you look at the shape of the 1.5 burr, the 1.5 burr is more well designed and is less likely to get trapped. But again, at the end of it, you have to make sure that you always come back to a neutral position after you've started your burring, and do not leave it beyond the lesion that you want to burr. We also have to be aware of the guide catheter sizes that one is going to use, and a 1.25 to 1.75 are compatible with a 6 French. And if you're going to move on to a 2.0, then you need something that is beyond a 6 French. The other thing that one has to be aware of is that the 2 wires that we talk about, the rota floppy and the rota extra support, they all are a 0.09 wire, but when it tapers down, the floppy part of the wire, or the distal most part of the wire, is a 0.1014. So the tip of the wire is of a bigger core or a bigger size as compared to the shaft of the wire. And why this is important for you to know is that once you're making sure that when you're burring, when you're doing a rotablation runs, you have to stay away from this part, because if you come very close here, then you can cut off the wire, or the wire can get damaged there, or can get jammed there. So you have to make sure that you don't come within the tip of the wire, because the tip of the wire is at 0.014, unlike the shaft, which is 0.09. The workhorse wire is usually the rota floppy wire. Rota extra support is used in very, very few cases, especially when you want a wire bias. If you want to really make a wire bias, then we may move on to an extra support wire. Then you have this small clip there that one has to connect at the end of the wire, or the distal most end of the wire. And this is to prevent the wire from spinning once you're doing the rotablation run. So this prevents the wire from spinning inside the coronary tree, and that has to be clipped onto the edge of the wire. When do we do an atherectomy? When of course you have severe calcium. But there are certain places where rotablation one has to be careful when one is doing a rotablation, and this is especially when there's severe tortuosity. So when you have a severe tortuosity, and if you're trying to do a rotablation, there's a risk of causing a perforation. Your rota burr may go outside the wire, outside the anatomical artery, and that is where one has to be careful. There are methods that have been described, something that is known as a half rota method, where you don't go the entire distance of the rota, but make a small peck only in the proximal part of the calcium in a tortuous vessel, just to make sure that you can get a balloon down there. But overall, as a learning curve, I think one has to be making sure that you don't go through very tortuous anatomies when you're doing a rotablation. The other thing is thrombus. Basically, when you're doing a rotablation, you're going to cause microthrombi going down to the distal bed. And if you have a thrombus that is there, you're more likely to cause distal clogging of microcirculation. So even if you've done a rotablation, if the distal microcirculation is clogged, there'll be no flow going into the distal circulation, and the patient can have a real problem. And if you have a major dissection, so if you've done a balloon dilatation and caused a massive dissection, one has to be careful to use a rotabler there. And of course, in a bypass graft, well, you can do it, but this requires a special amount of skill and not something that you should start off as a beginner. So it's basically used when you have a balloon uncrossable and a balloon undilatable lesion. The other atherectomy that is done is orbital atherectomy, but rota has an advantage, is that since it does not have a nose cone, it can be used in patients with a balloon uncrossable lesion, whereas an orbital sometimes may have a little problem. Of course, you can still use it in uncrossable lesions, but because the nose cone of the orbital prevents you from going deep, if you have an uncrossable lesion, sometimes you may have a little problem in using an orbital atherectomy rather than a rotational atherectomy. Again, as I said, you could use either of them. An orbital atherectomy again is used when you have a larger vessel. So if you're doing more proximal LAD, proximal left main, then those are the places where you'd probably use a burr orbital, because you get a larger surface, larger luminal gain when you're using an orbital atherectomy as compared to a rotational atherectomy. And the other thing is that the distal microcirculation or the distal embolization with an orbital is much smaller. It's just 2 microns as compared to rotational, which is much greater. What about pacemakers? So pacemakers are not usually needed in most of the cases, unless of course you're doing a dominant right coronary artery, or you're doing it into a circumflex artery, which is dominant without a co-dominant right. So if you have a dominant left dominant circulation with a major circumflex that you're going to be doing your rotational atherectomy in, or if you have a dominant right coronary artery, one would want to keep a temporary pacemaker backup. And there are other methods also that you can use. You can use pharmacotherapy with aminophylline that is often used, and that acts as an adenosine receptor blocker and that's the way it prevents my distal spasm and distal clogging of microcirculation. If the patient has a poor LV dysfunction, if the patient has poor hemodynamics, is in low output state, has LV dysfunction, one may want to use some form of MCS, whether it's an impeller or it is a balloon pump. And you can also use it for patients who have a large area of ischemia or a sole surviving artery. If you're doing a rotablation of a single surviving artery, then one has to be careful to use some form of mechanical circulatory support in these patients. Temporary pacemaker, as I said, pure LED, usually we do not use a TPI, but if it's a dominant right or a dominant circumflex, when we would probably use a temporary pacemaker. The other ways to use it, as I said, is to use aminophylline. Or the third way that we often use is similar to that we use our structural heart disease, where we use pacing from the tip of the wire. We often use our CTO wires also, or our rotablation wire also. You can use that to pace from the wire itself. So that's one more method that you can use it. The black goes to the tip of the wire, and use the other wire, the red, or the cathode is connected to the indifferent electrode that is usually connected to the skin, and you can pace from there. But one has to test this before one does the procedure to make sure that you're getting an adequate pacing there. What burr size do we normally use? Well, we tend to keep a burr to artery ratio, artery diameter of less than 0.5. And if you're using, for example, a burring in a 2.5 artery, it will be a 1.5 burr, a 1.25 burr is what we would probably go with. But in majority of the cases, as I said, 1.5 is usually the workhorse burr that we use in majority of the cases. And once you're using a burr, as I said, if you need to upgrade, one has to be aware of the guide sizes that one uses, because each of these guides are compatible with a particular burr. Another thing that has to be understood is that unlike a CTO, where you have to have a good backup support for a guide, for a rotablation, you don't need to necessarily have a good backup support. A guide support has to be more coaxial. So it's always nice to have a supportive guide. You should not have a guide that's floating when you're doing a rotablation, but you don't need to have a guide that deep throats, because what you need is more of alignment rather than an aggressive backup in these patients. And what is important to have is to have a good coaxial support and to avoid pressure dampening. Why is pressure damping is to be needed? Because you need blood to flow into the coronary artery to make sure that there's distal wash off of the microthrombi or the microemboli that you're causing. So if you have a guide that is damping, then your flow into the coronary artery will not happen, and that's going to worsen the hypotension that this patient is going to have. In most of the cases, though the rota wire, as I said, is a 0.09 wire, it's a pretty flimsy wire to wire per se. So in most of the tortuous or in patients who have severely calcified arteries, it may be very difficult to wire de novo with the rota floppy wire. And therefore, what is usually done is that you use a workhorse wire to cross the lesion, and then use a microcatheter and an exchange for the rota wire in most of the cases. And if it is kinked, then one has to replace the wire. So if it's a kinking the wire, please do not go ahead and do a rotablation on this kinked wire, because you'll break the wire and you'll lose the wire in the coronary artery. Once we start the procedure, before we start the procedure, put the rotablation into the patient body, there are some preparations that need to be done. And there is what we call as the draw. There is the drip. So one has to connect a drip with a continuous flush, often with heparin or with some form of nitroglycerin and diltiazem that we use as a cocktail, and that is flushed through the rota catheter. There is something known as R, or an RPM. RPM is that before you put the catheter into the body, you put it on the wire, and you can test by looking at the speed. So the usual speeds that we use are 140 to 160, 160,000 RPMs. If you have to really go high speed, then you often go to 2 lakh RPMs also. But usually 140 to 160 is the speed that we normally use for our RPMs. So this has to be tested. Third thing that you do is to check the advancement of the burr. So outside, you have to hold the advancer and make sure that it is moving, so that your burr is moving forward and backward. And the wire, you have to make sure that the wire is moving inside and your guide brake is working and the wire is moving inside. So this is the acronym, the mnemonic draw is used before we start the procedure and before we start this. And one more thing you have to do is to lock the advancer knob at least 2 centimeters from the distal end. The reason for this is that after you've taken the rotablation inside, you push it back so that you remove the slack in the rota wire. And that is important for you to know, that you lock the knob before you take it in at least 2 centimeters from the distal end of the wire. There are methods of which you can, as a single operator, also get your wire in, but majority of times, since we have no dearth of operators to help us out, it could be a two-man procedure. So your second operator would be one who would be fixing the wire, and then you move your wire inside. Or if you're doing it as your own, what you could do is a single operator. You can also activate the Dynaglide mode and put in your wire, advance the burr into the catheter in the Dynaglide mode. One has to make sure that once the guide is into the neutral position or the starting position, your burr is into the starting position, you would move the advancer knob back to release the tension. There are reasons why you're not able to deliver the burr, and this could be tortuosity, poor guide support, non-coaxial, or because of other causes also. So the treatment, as I said, is to make sure that you change to a more supportive guide. If you have got kinks in your ilex, take a long sheath and make sure that you can remove have a coaxial coaxial alignment of the guide. Again, as I said, once you start the procedure, we have to use pecking motions. So just small, gentle pecking motions, and do not stall the burr beyond the lesion. Always make sure that you come back to the starting position. You have to give short duration, so it's less than 15 seconds and a gap of at least 30 seconds. So once you've done a burr for 15 seconds, make sure that you wait for at least 30 seconds for the microchannel circulation to restore. And this is what is the advantage of the Rota Pro, because here you can see the RPM drop also. So if there's an RPM drop of up to 5,000, it shows as a hollow triangle, and if it's more than around 10,000, then the triangle becomes full. So this will be helping you to know whether there's a significant RPM drop. If you have an RPM drop more than 5,000, one should be careful and come back and stop. Again, as I said, this is important to understand that you give short bursts, 15 seconds, and then give a long duration between the burr time, and not give long duration of burring and short duration of inter-burr times. This is important to realize because this is like a sink. So if you have sand there, and if you have putting in water, unless you give time for the sand to wash out, the sand will just accumulate there and it will plug the sink. And this is the same thing that happens if you give a long duration of rotablation and give short periods of rest between the bursts. Again, I think your time is short. Again, the Dynaglide mode, after you've done the rotablation, you need to remove it, and the removal is done in the Dynaglide mode by trapping the wire. So I think, okay. So contraindications. So contraindications are basically, I think, as I said, if you have a tortuous artery, one would be a little careful. If you have a thrombus in the artery, one has to be careful. And of course, if you have extensive dissections, then one has to be a little careful. Other than that, it's a safe tool in majority of the hands. And I think it's a tool that is essential, especially because we have an aging patient population that we're going to be treating now. And you would end up having the requirement of this tool sometime or the other when you're treating your calcium. Thank you.
Thank you, Professor Aftab Khan, for your nice demonstration on tips and tricks on rotablation. Two of our respected panel expert is here, Professor Imad Shiban and Professor Dr. Qasim Nasrullah Khan. Any questions from the audience, please?
Dr. Aftab, is there any data for complications like dissection and perforation?
No, so rotablation per se does not cause too much dissections. Perforations are known, and that is the reason that one has to be careful.
Endothelial disruption.
Yeah, so I think the advantage of rotablation is that it works on the basis of differential cutting. So it's not it will be the calcium or the fibrous tissue or the hard tissue that will get damaged or it will get sort of sheaved off. The soft tissues does not get sort of affected by this. So that's the advantage of, or the basic concept of differential cutting is the fact that your normal tissues will get deflected, but it will be the hard tissue that will get modified, it will get sort of chopped off.
Perforation.
Perforations are known when you have sort of tortuous vessels. So one has to be careful when you're doing tortuous vessels. And unfortunately, that's where most people tend to mistake. When you have a tortuous vessel and if you try and do a burr, or if you don't do the gentle pecking movements and you try to be very aggressive, and that's the time that your burr can really exceed, and especially with the small burrs. So if you have a 1.25, that's like a bullet, and that's sometimes does end up with causing problems if you're not very careful.
Thank you. Thank you.
It's like 160 or something, and you started rota, and then it falls down to 1. Is there any difference? Like
Yeah. So
How much we allow the speed to go down?
More than 5,000 RPM drop, one has to be careful, and then one needs to be stopping for some period of time. So don't, if there is drop of more than 5,000, just go a bit slow, and you have to wait for the burr to come back, because that basically means that your burr is not, it's stalling there. And if your burr gets stalled there, then you're in trouble. It may not come back, and you'll have a jammed burr there, a trapped burr, as we say. Yeah.
Start from 140.
140 to 160 is the same, but if you don't get if it is not crossing, you may go to high pressure. You may go to 2,000 to 2 lakhs, or sometimes the other thing is to downgrade to a smaller burr. So if you've gone to one, supposing as I said 1.5 is my default, and I've tried at 1.160 and it's not really crossed, I may go from 160 to 2 lakhs and see whether it crosses. If at 2,000 RPM it's not crossing, what you do next is to downside your burr rather than going a very high pressure, high speeds. Right?
How many times you should get chance to do it? How many times?
Yeah, so there's no, see, sometimes you may require, so the important thing to do is to go small and go gentle. So even if you require runs of say 7 minutes, 7 runs or 8 runs, that's nothing to worry about. So as long as you have a good flow, as long as you're giving enough nitro into the vessel, so you must make sure that you let the time, the artery should be given time to breathe. If you keep on doing and not let enough time between the runs, then that's the time that's going to produce slow flow and clogging of the distal vessels. So time is not the matter, but again, if you have 4 or 5 runs that you've done and you're not getting adequate response, then you must make some changes, either increase the speed or come down on the burr size to make sure that you can probably cross. Yeah. Yes, the side branch wire has to be removed. There are certain cases where you could keep your micro catheter and do it, but I think those are not really something that is essential, because side branch access is very well preserved when you're doing a rotablation. So unlike a balloon, when you can cause dissection and cause a side branch to shift, side branch loss in a rotablation is really not that common. Yeah.
Should do OCT before must to see the morphology of the.
Well, again, as I said, rotablation is sometimes used for balloon uncrossable lesions. So many times it happens that you may not be able to cause your OCT or your IVUS catheter to cross. So you may have to jam your IVUS catheter in the proximal part and then look at it. And OCT, the problem is that we have a very critical lesion. Then the OCT, since there's no wash off, you may not get a very good image to start off itself with. So your IVUS may show the proximal part of the lesion and you may not be able to cross it. It's not essential to do it before the procedure, but yes, if you can do a small balloon and you can get your IVUS down, that may be the way to do it. Yeah. I think one of our speakers has a compilation session. So I think they'll speak to him.
You have mentioned one point, that is half rota for the tortuous vessel. Do you have any practical experience, sir?
Yeah, so I think Professor Shivan is also here. So what we have to understand is that when you have a tortuous lesion, the main problem is that when you have a tortuous lesion, the intention is not to cause go down with the burr, because you're going to end up causing a perforation. The burr may not take the thing, it may go out, right? And therefore what we do is that the basic intention is to make it from a balloon uncrossable to a balloon crossable lesion. So if you're able to modify the part of the burr or the part of the lesion before it bends down, or before it gets into the tortuous part, do only the proximal part or just before the bend itself without going down, that is known as a half rota. So that's been well described, but it modifies the proximal part of the plaque so that you can then get probably a balloon down with your adequate supportive material then. Yeah. No, there's no difference between the radial. You can do it with either ways.
How do you avoid the wire bias? What's the problem with the wire bias?
So the wire bias is basically when you have a tortuous vessel, the wire would tend to go on the inner surfaces of the vessel, right? And if you have a wire bias that is there and you do a burr, what may happen is that, for example, in the right coronary artery, and you have a wire that goes down, it may hug the inner side of the vessel wall. And if you do a burring there, what may happen is that you may create a separate tunnel there. Rather than going into the center of the artery, you may be burring into one of the side of the arteries. In which case there is a separate channel that is formed, or a separate cavity that is formed there, and you have a risk of perforation also. So therefore you have to make sure that you leave a slack in the wire, and therefore one of the ways is to make sure that you let the wire be central. You pull back the wire a bit so that it lies within the artery, rather than making it go absolutely down where it hugs the inner wall of the vessel. So that is one. So there are certain places where we don't want wire bias. You want to make sure that you don't get a wire bias so that you're not boring into the inner curves of the vessel. But there are certain other places where you want a wire bias. For example, if you've seen an IVUS and you've seen that when you have, say, a calcific nodule, and your wire is towards the calcific nodule on an intravascular ultrasound, then we would prefer a wire bias. In those cases, you want the wire bias to be there so that when you're burring, it is going to be chopping off the calcific nodule and not the other wall of the vessel. So there are certain places where wire bias may be needed, but then most of the places we don't want a wire bias, and we have to make sure that we don't end up causing this problem there. Yeah.
You have said everything. So but about wire bias, I think the most important challenge in rotablation is calcification in tortuosity. That's the most, and you should not push. Should go picking. You should sometime also de-escalate the bar, smaller one. And if you are not crossing, don't insist, because you can have the bar stacked in the artery, and then it becomes a real problem. Or you can perforate as well. So sometimes, rare times, you can fail also with rotablator. So keep it in mind and accept it.
Sir? Our next presenter is Dr. Abdul Kaim Khan. He will be talking on rotation case-based discussions, because our